Yes, sir.
Okay, so we are looking at EP. Okay. So basic part about EP is I'll do it more of explain. The basic purpose of this slide is just to capture the images we see on EP. However, it's important we know what we actually do in EP. We're all cardiologists, so the basic purpose of EP is for both diagnostic and therapeutic. So diagnostic in the sense that patients that have arrhythmias, we want to know the type of arrhythmia they have, the mechanism of the arrhythmia. The EP can diagnose the mechanism, and also to now give a therapeutic intervention of arrhythmia. EP can even if it's a junctional reading, whatever it is. And even if also in bradycardia also, it can also help you diagnose whatever the type of bradycardia it is. Either it's first degree block. You cannot diagnose that on EP. So, as I said, EP is diagnostic and therapeutic. Other important information we should have with us is that EP can make diagnosis when the cause, as in the arrhythmia, is not known. So, for example, what do we mean by that? So, for example, you've been following up a patient, either symptomatic or not. ECG has been normal. You've done Holter. Holter is normal. Loop recorder that's implanted and is recording the act activity just like an Holter, and that can take longer, can take months. And done than normal, EP can help in the diagnosis actually on. So that is the benefit of EP. It's like a gold standard for any form of arrhythmia that cannot be picked by other investigations. So remember we said it helps us to make diagnosis and treatment. And remember we said it's not a mechanism of the arrhythmia. So as we all so there are three mechanisms basically in arrhythmias, which we all know. So we have increased automaticity, reentrant mechanism, and triggered effect. Okay, so for automaticity, as we all know, it's like an overdrive function of the so meaning that there is a focus in the heart that is running, that is kind of generating faster or generating electrical activity faster than that can be from the SA node.
Hello, sir. We can barely hear you. Your line is coarse.
I'm still audible.
You are, but you're coarse. Like your network is fluctuating.
So to which segment? I think I should change network again.
Sorry, sir.
Can I confirm if the network is better now?
It's a lot better. I can hear you loud and clear.
Okay, I have to change
Thank you,
network.
sir. Thank you, sir. Sorry for the inconveniences.
No problem, madam. Just to confirm if the slide is moving.
Yeah, I can see your slide.
Okay, so would you get the introduction of the purpose of EP?
We got it, but we don't mind if you,
Okay.
because, yeah, thank you, sir.
So as I said, the main purpose is to make a diagnosis and also for therapeutic intervention. So diagnosis, we're saying that whatever the arrhythmia it is, EP can help us in making the diagnosis. So and we listed whatever form of arrhythmia, either it is an tachycardia arrhythmia or a bradycardiac arrhythmia. No matter the location of the heart it's coming from, EP is the gold standard for making a diagnosis. Number two is that when you've done all investigations like Holter, ECG, loop recorder, and you cannot unravel the underlying arrhythmia, EP is the way to go. Number three, it not only confirms the type of arrhythmia, as I said, either tachy or brady, it can also identify the mechanism of arrhythmia. Okay. So, as we said, we said there are three mechanisms for arrhythmia, which is increased automaticity, reentrant, and triggered effect. As we said, increased automaticity is more related to anything taking over the pacemaker function of the heart. That means, just 1 second. The automaticity itself is that if we follow the action potential curve graph from the phase 0 to phase 4, in patients that have that increased automaticity, they have a very unstable phase 4. So the phase 4 period is shortened and it triggers faster than the SA node. Now, this increased automaticity can happen even within the tissue of the SA node or outside the SA node. That means any arena in the heart. It's usually a single focus. It would conduct through any conductive segment of the heart faster than the pacemaker of the heart. That can be identified during an EP. Number two is the reentrant tachycardia, which we would discuss further because most arrhythmias are classified. Their mechanism is actually mediated by reentrant tachycardia. So it simply means that there is a circuit that must be formed before you say the patient has a reentrant. There will be a circuit that would, is a particular segment of the heart that would conduct, and there will now be another segment of the heart that will return the electrical activity, forming a circuit. We'll discuss this further. A triggered activity, we all know, is increased electrical activity, especially at the period of refractory or the relative refractory period of the heart. So I'm not going to detail simply because I'm sure we have studied things around it. But when we talk about triggered activity, we are talking about around the phase 3 of the action potential, where there is the absolute and relative refractory period. So the end part of the phase 3 is where a triggered activity would happen, and usually triggered by the ion channels, especially the potassium channel, when it's meant to be opened, but probably is closed early. So that would happen in areas where there are scar tissues. So there will be increased bursts of action potential in that arena, and that can generate the arrhythmia. So it's not as common as reentrant mechanism. As I said, most of the 90% of arrhythmias are under reentrant tachycardia or reentrant mechanism. So one other important thing we should note that our EP would help us identify is to identify the arrhythmia classified either, especially so for SV, so if we're talking about supraventricular tachycardia, they try to classify it under long or short RP tachycardia. Now, so it's important to know this long and short RP tachycardia in order to know what type of arrhythmia you are dealing with. Okay, so RP will be the time interval between the R wave and the P wave. So that time interval is very important. So there is a cutoff time interval that classify the arrhythmia into either long or short RP, which is 70 milliseconds. Now, one important thing we should know is that when it's a long RP tachycardia, mediated tachycardia, these are the possible differentials that can happen in a long RP tachycardia. So it could be atrial tachycardia, SA node, reentry tachycardia. Remember I said reentral activity can happen even within the SA node or any other tissue. It could also be sinus tachycardia, AV-NRT, or AVRT tachycardia. Okay. Now, a short, but one important thing is that for short RP is more classical for a typical AV-NRT. Atypical AV-NRT usually under long RP tachycardia, while the typical one, AV-NRT, is going to be under a short RP interval. So that's what we have here, that the typical AV-NRT will be under a short RP interval. So I've already informed us that the time interval we're talking about is 70 milliseconds. When we calculate the interval, that's the interval between the R wave and the P wave. Okay, that other features of short RP can also be the autodromic AVRT. So I would further explain why these two are usually under short RP interval and why the others are under a long RP interval. So coming to this slide, we all know this slide. And this is very important when we're discussing EP. Knowing the location of your SA node, the location of your AV node, the bundle of E's, and its division. So when we pass the catheter, we are trying to get our catheter close to these conductive tissues so as to monitor the arrhythmias in them. Also, it's important to know the location of the coronary sinus, the CS, because the catheter will pass through it to the back of the heart where the coronary sinus is, and is going to be detecting activity between the left atrium and the left ventricle. Hope I'm audible. Hope I'm still audible.
Yes, you are, sir.
Okay, so please, at any time you have questions, please let me know. Now, so as I previously said, our catheters are passed to a segment as close to the conducting tissues as much as possible, so as to mimic or identify activities around that conducting fibers. As much as possible, our catheters are passed close to it. Now, so you see a catheter here in the right atrium. I hope we are not being distracted.
So Dr. Conte, please just help me mute. You're the host now, Dr. Conte.
Okay, thank you very much. So the catheters are passed close to those conductive tissues. So for example, now, this is a catheter in the right atrium, and you will notice that the catheter is close to the roof of the right atrium, simply because the SA node is at the roof of the right atrium. And so they usually will call this I right atrium catheter. HRA is a short code. So I right atrium, you see it when we're seeing the graphs. So meaning that it's monitoring SA node activity. So it can be used to stimulate the right atrium, and it can also be used to sense electrical activity in the right atrium. The next is, you see a catheter close to the AV node or the E's. So it's usually called HIS catheter, E's catheter. So it helps us to see the conduction time between the atrium and the ventricle. So you will see, it helps you to monitor your AV node activity. So all the AV node time and things like that, it's the E's catheter that is going to help us to know the conduction property of the AV node. So another catheter can be passed into the coronary sinus to the back of the left atrium. So the purpose of this catheter is just to monitor electrical activity in the left atrium and left ventricle. So basically, you just want to monitor activity around the left atrium, because at the back is in the junction between the left atrium and the left ventricle, because in the coronary sinus, which lies in the atrioventricular groove. So the last catheter is usually passed into the right ventricle, okay? So sometimes you can puncture the interatrial septum and pass a catheter into the left atrium, but the basic testing that is done is that a catheter will be in the CS, a catheter in the East, a catheter in the right ventricle, which is not shown on this picture, and a catheter in the right atrium. Now, catheters can now be placed in any other segment as you wish, in case you want to monitor activity in other segment. Like a patient will have atrial flutter now, and we know that flutter activity can run through a circuit in the right atrium. So you can put a catheter, a circular catheter in the right atrium, so as to monitor the wave pattern, how it is going, either it's a clockwise or an anti-clockwise flutter. Okay. So basic part is that these catheters monitor electrical activities like doing an ECG. So it monitors the deflection, electrical activity happening in that chamber. This is very important to understanding the tracing and the graphs seen in EP. So it's important also to note that, remember we said that the most arrhythmias follow a reentrant circuit mechanism. So if we have that in mind, then we should note that for you to say that there's a reentrant mechanism, that means there must be tissues that would form a full circuit, a circular circuit, for that activity to happen. So, and commonly for AV nodal reentrant tachycardia, the tissues that mediate this arrhythmia is usually in the AV node. So that means there will be a fast pathway and a slow pathway in the AV node. And there will be conducting tissues in the heart muscles that would make the circuit complete. So meaning that the circuit must join each other for the activity to complete a reentrant circuit. So we are trying to emphasize that even within the AV node, there will be a fast pathway and a slow pathway. And that is what generates this tachycardic mechanism. And when you are also ablating, ablation is just like burning off, or like using a diathermy to burn off something. So when we're ablating, we are also targeting that tract so as to terminate the tachycardia. Okay. So we've discussed this about how the activity happens. But if the patient has AVRT, either Wolf Parkinson White, any form, or Miami fibers, any other kind of long Ganon White, all those other mechanisms would work outside the AV node. So the conducting AV tissues would be one limb of the circuit, while the aberrant tract will be the other limb of the circuit. So that would also complete the reentrant mechanism. So that this brings us to this diagram, which we have all studied before. We're trying to know the mechanism of reentrant tachycardia. As I previously said, either it is in the AV node or there is an aberrant tract. There will be two limbs that can conduct activity in whatever direction, either an antegrade or retrograde direction. That's number one. Number two is that these two tracts must be able to have tissues that will connect them for a circular circuit to form before the tachycardia can be generated. Why did I say that? You cannot have a tachycardia without the circuit being complete. Number two, the tissue that combines them must have a connection, sort of. So, for example, I'll go back to this tissue, to this diagram. So, if you have AVRT, meaning that the person has an aberrant tract on the wall of the left ventricle. So, even if the aberrant tract stops here, so the wall of the ventricle will be the remaining conducting tissue, so that it can conduct to the east bundle, which will get to the AV node, and for the circuit to complete its circus. Okay? One important thing we should note is that when you treat someone that has AVRT and you burn off the fiber, one important thing is that as long as you have burnt off the fiber, remnants can remain. Now, it's not important to know the property of that remnant. The property is that could it be that it has been burnt sufficiently that even though the remnant cannot conduct any activity, that is a successful ablation. Or it's burnt off that there's no more remnants. That's another successful ablation. And as long as that has happened in both scenario described, the activity of circus would not be mediated, cannot be completed. So the patient cannot go into any more tachycardia. Okay? So I'm trying to emphasize the fact that when we are ablating, you either ablate to completely eliminate the tract or ablate to damage the tract that nothing would, no activity can pass through it anymore. So those are evidence of a successful ablation. Now, going back to our mechanism which we all know before is that there should be activity that would generate the circus. So, for example, if we take the AV node, for instance, as our activity line. So the AV node, when electrical impulse is coming from the atrium, it passes through the two of the fibers in the AV node. You said there's a fast and there's a slow pathway. So what are the features of the fibers? So for the fast pathway or the fibers, it conducts electrical impulse faster than the slow. However, it has a longer refractory period. Okay? Meaning that if you try to send electrical impulse to it, when is in its absolute refractory period, is not going to conduct. For the slow pathway, it conducts slower, but has a shorter refractory period. So simply meaning that it is very vulnerable for electrical activity to pass through it in the refractory period because of a shorter refractory period. So that property is very important in the mechanism of arrhythmia. Number two important thing is that when we use medication, so the purpose of the medication is to alter that activity, that property. Medication does not damage the fibers. It only alters the action potential around those fibers so as to suppress the electrical activity happening in that tissue. So that's why if you are reading your antiarrhythmic medications, you will see the class 1, which will tell you, oh, class 1 would reduce conductiveness. It would prolong, depending on either it's A, B, or C now, which one will prolong the refractory period. Another will shorten the refractory period and things like that. So all they are doing is to modify the conductive nature of that fiber so as to suppress electrical activity conducting through the fiber. Now, how does it form its circuit now? For we already know the nature of these fibers. We said there's a fast pathway which conduct electrical impulse faster, but has a longer refractory period. There's the short path, the slow pathway, which conducts electrical activity slower, conduction is slower through it, but has a shorter refractory period and makes it vulnerable for an ectopic impulse to pass through it. So in a normal patient, when electrical activity happens and it passes through the fast pathway, it will also pass through the slow pathway. However, when the slow pathway is getting to the area of the fast pathway or getting to the ventricle, because the fast pathway has already conducted activity through it, the ventricle or the fibers, the East bundle would be in its refractory period. So that means conduction will not happen. So it will be blocked. So that is how activity happens every time electrical impulses passes through the fast pathway. If it's passing through the slow pathway, it will get blocked because the East bundle is still in its refractory period. Just a minute. So, however, there'll be a time that an ectopic premature activity can happen. In the sense that when the premature activity happens, then remember, first fast pathway as previously conducted before the premature activity happened. Now, so when the premature activity now happens, now it can, remember we said that the slow pathway has a shorter refractory period. So it makes it vulnerable to accept a premature conduction. So when that happens, it would accept the premature conduction, and that can now fall on the east in its relative refractory period. You know, in a relative refractory period, simply means you can still stimulate that tissue compared to an absolute refractory period. So it can fall on the east during the relative refractory period, and immediately it falls on the east during the electric refractory period, then it will get conducted. So if it gets conducted, the fast pathway will now be in its own electric refractory period too, which can also conduct upward. Always remember that these fibers, as we said, they are like wires. Your wires at home, the copper wires, the whatever electrical wire you have, can conduct electricity in both directions. Meaning that if you plug the wire one end of the wire to electricity, and you connect the other end to a mobile or whatever, electricity will pass through it. If you switch over the wire, meaning that the previous end that you connected to the light source, electrical source, you change the direction and connect the other end back to the light source and its own end back to any other thing that can conduct, it will still conduct. So we're trying to say that your wires at home can conduct in any direction. Any of the ends can conduct electrical activity. So the same thing is evident in the fibers of the heart. They can conduct downwards and they can conduct upward, meaning it's antegrade or autodromic and also retrograde conduction. Okay, so having that in mind, we said when the premature conduction pass through this slow pathway because it is vulnerable, it has a shorter refractory period. When it conducts a premature electrical activity, it will hit the East bundle in its relative refractory period, and that will stimulate the East again to conduct down. The fast pathway will now also be in its relative refractory period, and it will conduct in a retrograde direction back to the atrium. So when that happens, then the circuit has been formed. So that is the most common mechanism for forming reentrant tachycardia. One important information we should note is that most patients would have a fast, slow pathway. Some patients can also have fast pathway, and some patients can have slow pathway. Whatever, but the most common is the fast, slow pathway. One last information we should have is that when we say a patient, okay, just 1 minute. So when we say a patient has AVNLT, that means that the pathway that is mediating the circuit is in the AV node. So that also simply means that there'll be conduction through the fast pathway through the fast pathway, and when the premature complex comes, it will conduct through the slow pathway, which will now take the fast pathway as the retrograde conductor back up. Now, one important thing here is that as long as it is the fast pathway that is taking the retrograde conduction up, because of its speed, and the slow pathway is the guy bringing it down, the patient would be having depolarization of both the atrium and the ventricle at the same time. Remember, we said the pathways are in the AV node, they are close to each other. The guy that initiated this arrhythmia was the atrial premature complex or any premature complex from anywhere that passed through the slow pathway. So when it passes through the slow pathway is conducting it to the East bundle, but it communicates with the fast pathway to complete the circuit. So the fast pathway will take the conduction back to the atrium. So as the East bundle is depolarizing the ventricle, the fast pathway has conducted rapidly to the atrium, and so both atrial depolarization and ventricular depolarization will be happening at the same time. So, simply meaning that if you calculate your RP interval, it will be short. So the RP interval being short is a typical feature of AVNRT. The typical AVNRT. Hope this is clear. so that we can see why we classified AVNRT as a short RP interval. Dr. Florence, I want to be sure, is it clear? Hello, am I still audible?
Yes, Prof. It is very clear.
You are, Prof. It's clear.
No, Professor Kupi, how can you be saying it's clear? Yes, understand.
Okay, sorry, sir.
Please I need to be sure others are getting this thing.
Dr. Florence, are you not there? Chineme? What about Chineme?
Oh,
Okay.
need to just be Dr. Sorry.
Yes, sir. It's clear, sir.
It's very
Okay.
Clear, sir. We understand. Yes, sir.
okay.
All right.
So that you can see the reason why this usually classify the typical form of AVNRT will have a short RP interval, simply because the fiber carrying the electrical activity to the atrium is the fast pathway. The slow pathway is carrying it through the ventricle. But remember that the problem started from the slow pathway. So that means the ventricle will get depolarized early before the fast path, before the atrium. But because the guy carrying the activity back to the atrium is the fast pathway, so that means that the atrial activity will be almost happening coincidentally at the same time with the ventricular depolarization. So that is why you have a short RP interval. So I just need to be sure that this is very clear. Okay, so hope we can move on. So if that is well understood, then we can go to AVRT. So for AVRT, we all know that the aberrant tract is in another segment of the heart. It's not in the AV node. Okay? Or can be close to the AV node sometimes. So that is why we talk about paraischian tract, meaning that it's not in the AV node, but it's so close to the AV node, so it's paraischian, just by the side of the east. Okay, but the typical one, it can be on the free wall of the right atrium conducting to the right ventricle, or it can be in the free wall of the left atrium conducting to the left ventricle, so the AVRT. So now one important thing we should note about this is that depending on the direction of conduction, first, it must form a circuit, as we are seeing on this diagram. Now, depending on the direction of conduction, it can conduct through the aberrant pathway from the atrium to the ventricle and conduct back using the normal conducting tissue of the heart, which is the east bundle and the AV node. And the circuit and the atrium tissue will conduct it back to the aberrant tract, and the circuit would continue. Okay, so when you have the mechanism in which the electrical activity is conducting down through the aberrant pathway and conducting up back through the normal conducting tissue of the heart, which is the east bundle AV node, then you will say the patient has an antidromic pathway. Antidromic because it is going in the opposite direction of the normal conducting tissue of the heart. Okay, so in this kind of patients, you will see the time interval it takes to conduct down through the aberrant pathway and the time interval it will take to conduct back up. So the antidromic would always give you a long RP interval, meaning that it depolarizes the ventricle first and goes back to depolarize the atrium. So the antidromic form of AVNRT, so the AVRT, that means atrioventricular reentrant tachycardia now, will give you a long RP interval. Okay. Now, so the converse is with the orthodromic. So the orthodromic simply means that, well, the conducting fibers would conduct electrical activity down its normal fast tract, which is the bundle of E's and others, but it will get conducted back to the atrium through the aberrant tract, which is usually a fast tract also. So because of the speed of the aberrant pathway to conduct back upward, that can give you a faster depolarization of the atrium, coincidentally colliding with the time it is depolarizing the ventricle. So when you have that conducting tissue conducting part through its normal tract to depolarize the ventricle, and the aberrant tract conducting back to the atrium, and the aberrant tract is a fast tract conducting the atrium, that means that the time interval you are using to depolarize the ventricle, the fast tract are taking it up back to the atrium to depolarize the atrium. So the time interval between the ventricular depolarization and the atrial depolarization will coincide almost to the same time. So that would give you a feature of an orthodromic atrioventricular reentrant tachycardia, AVRT. Okay, so that is why AVRT differential would also be, I mean, the short RP interval could and also be the AV orthodromic AVRT, but not the antidromic AVRT. Okay. So if this short RP interval has been well understood, then we can now tell you why sometimes AVNRT can also give you a long RP interval. Now, remember, we said that there are some patients, going back to this slide, we said there are some patients, most patients would have fast and slow pathway. There are some patients that can have fast pathway or slow pathway. So if a patient has a slow pathway, it's
Prof, we can't
simply
hear
means,
you again.
remember, it conducts slowly, but has
Prof, you're muted. Hello, Prof, you're muted.
yeah. Hello? Is my network still there?
Okay, you're better now. Thank you, sir.
Okay. Okay, I think I try to emphasize the feature of why, I think I've tried to establish why the normal or typical AVNRT will have a short RP interval. And I've also emphasized the reason why orthodromic AVRT, that means atrioventricular reentrant tachycardia, would have a short RP interval also. I've tried to also establish the reason why antidromic AVRT would have a long RP interval. I want to be sure these three are clear enough. Why typical AV-NRT would have a short RP interval, while a autodromic AVRT would have a short RP interval, and why antidromic AVRT would have a long RP interval. I want to be sure if that three is clear enough, because this is just the basis of understanding anything we are doing in EP. Is it clear? I need to be sure. If it's not clear, let me know so that I can
So
emphasize.
sorry, sir. Please, can you repeat that of antidromic AVRT? How it has a long RP interval?
Okay, sure. But is the one for AVNRT the typical one? Is it clear why it has short RP interval?
Yes,
And autodromic AVRT, why it has a short RP interval? Is it clear?
50-50.
Okay. So
Thank
let's
you, sir.
go back to this one.
Autodromic is not clear. Oh.
Okay. So I'll explain again with this. So it's just to know the nature of the tract. Okay. So the nature of the tract for autodromic and antidromic is that we all know that the second limb that carries the tract is not in the AV node. It's any other segment, arena of the heart that conducts atrium to ventricle that is outside the AV node. Okay? So the nature of that tract can be a fast tract or a slow tract, but usually they are actually fast tract. Okay? Number two is that we all know that autodromic simply means you are conducting from the AV node to the east bundle, right and left bundle, the tissues of the ventricles, the aberrant tract up back to the atrium. So it's autodromic because it is using the normal conducting tissue of the heart to conduct electrical impulse from the atrium to the ventricle. While it is using the aberrant tract, which is usually a fast tract, to conduct electrical activity from the ventricle back to the atrium. Now, because this tract is fast, very fast, it would conduct very fast to the atrium. And normally, you will conduct from AV node to the east bundle, right and left bundle, and you try to depolarize the ventricle, both the right and the left ventricle at the same time. But because there's a very fast tract that is taking the impulse back to the atrium, it will quickly get the electrical activity to the atrium and depolarize the atrium. At the same time, when your normal conducting tissue is depolarizing the ventricle. So that tells you the nature of that aberrant tract, because it's a very fast guy that takes the electrical impulse back to the atrium. You understand? So if it's very fast to conduct back to the atrium, that means that the same time when you are still depolarizing the ventricle, the aberrant tract has quickly conducted to the atrium to depolarize the atrium. So that means that the atrial depolarization will be coinciding with the ventricular depolarization at the same time. So that is the autodromic feature of AVRT. Is that one clear?
Yes, sir.
It's just that this
Yes.
aberrant tract is very fast to take it back up. So as long as it's very fast to take it back up, by the time we are depolarizing the ventricle, it has already also depolarized the atrium at the same time. Okay, so if that one is clear, then we can now go to antidromic. So antidromic says that we would take the electrical activity from the atrium very rapidly to the ventricle, right? While the now normal conducting fibers, the right bundle, left bundle, from the Purkinje to the right bundle, left bundle to the east bundle, back to the AV node, you will now use that one to conduct it back to the atrium. It is not as fast as the aberrant pathway. Okay? So mean that the aberrant pathway will quickly come and deplies the ventricle, while the normal conductive tissue will now have to take it back to the atrium. So that means there will be a significant time interval between when you depolarize the ventricle to the time you are depolarizing the atrium. Do you get that? So that will give you a long RP interval. R for the ventricle and P for the atrium, because it takes longer for the normal conducting tissue to take it back to the atrium, while this aberrant tract will quickly conduct it fast again to the ventricle to depolarize the ventricle, but it will take some time for the normal conducting tissue to gather it back to the atrium. Hope that is clear.
Yes, sir.
So that is why
Thank you,
the antidromic property would have a long RP interval, because it takes longer for the normal conducting tissue to take it back to the atrium. Any question? Let me
Hello,
know.
sir. Please, I have a question.
Yes, tell me.
Okay, sir. Thank you so much, Prof. I just want to get some clarification between the autodromic and then the antidromic, because I realized that you mentioned about the fast pathway. Now, does it mean that both the antidromic and the autodromic has both the fast pathway and then a slow pathway?
Okay, so
Thank you, sir.
okay, are you done? Are you done with the question?
Yes, I am, sir.
Okay, sir. No, so what I'm trying to emphasize to you, sir, is that when we talk about fast pathway, slow pathway, we're talking about AV nodal reentrant activity, AV node. When we are talking about AVRT, we're only talking about aberrant pathway. And the aberrant pathway is a very fast tract. I want you to get that clear. You get me, sir? Hope I'm audible.
Yes, sir. You're audible,
Yes,
sir.
sir. You're audible.
Okay, now it's fast in whatever direction it's going. Either it's going to the ventricle or it's going to the atrium. If it's going to the ventricle, that means it's going to give you an antidromic pathway, right? So if the aberrant tract is taking this electrical activity to the ventricle, so it's going to be antidromic. So it quickly gets to the ventricle to depolarize the ventricle, while the normal conducting tissue, AV nodal delay and all that, it will take time to get back to the atrium. And the moment it senses the activity in the atrium, it quickly conducts it back to the ventricle, right? So that means quickly depolarize the ventricle. Then the conducting tissue of the heart will take it slowly back to the atrium, right? And there will be a significant time interval between when you depolarize the ventricle and when you are depolarizing the atrium. So this aberrant pathway is usually, most of the time, a very fast pathway. You get it, sir? Unlike when you are doing autodromic, always remember autodromic, that the guy that is bringing it down is the normal conducting fiber. The moment the normal conducting fiber is depolarizing the ventricle, the fast pathway, which is the fast aberrant tract, will quickly take it back up to the atrium and depolarize the atrium at the same time. Do you get that circus now? So then it gets to the conductive tissue. That one brings it down to depolarize the ventricle. As it's rising the ventricle, the fast aberrant tract has taken the signal back to the atrium to quickly depolarize the atrium. So that means that the atrium and ventricle will be almost depolarizing at the same time because this fast aberrant tract is conducting it fast to the atrium. So that is why orthodromic would give you a short RP interval compared to the antidromic. Antidromic could be slow or will be long RP interval because the fast apparent tract has conducted to the ventricle, is quickly divided the ventricle, and is now using the normal conducting tissue of the bundle of V's and all that to take it back to the atrium. So there's a significant time interval between when it depolarizes the ventricle and before it gets to the atrium. So that will give a long RP interval. Is that clear, sir?
Yes, sir, it's clear, sir. Thank you, sir.
Okay, so this brings us to the fact that since we've understood that part of AVRT, which can either fall in long RP or short RP, and we said the typical AV-NRT, AV nodal now, ventral architecture, is the one that has the fast and slow pathway. So when we talk about fast and slow pathway, we are actually referring to AV nodal ventral activity. When we're talking about aberrant tract, we're talking about AVRT. Now, when we talk about the AV-NRT having a fast pathway, the fast pathway will quickly take it back up, while the slow pathway is the guy that is the one that received the premature complex that initiated this tachycardia. So it takes it to the ventricle using the East bundle. As it's trying to depolarize the ventricle, the fast pathway has taken it back very fast to the atrium. Right? So that means that the time you are depolarizing the ventricle, the fast pathway has quickly gone back to depolarize the atrium. So that will give you a short RP interval. That is the typical form of AV nodal reentrant tachycardia. Okay? Now, we now have some patients that have slow pathway, right? And we say slow pathway means that it conducts slowly, right? So let's say the same patient that has slow pathway now has a premature complex that broke into the circuit. When one of the fibers slow pathway is conducting down to the ventricle through the East bundle, the other slow pathway will take it up back to the atrium, but slowly, right? Since it's slow, that means that you will quickly depolarize the ventricle faster than the slow guy getting back to the atrium. So that means there will be a long RP interval because the slow pathway brought it down, is depolarizing the ventricle, and the other slow guy has now also conducted back up slowly to the atrium. So there will be a significant time interval between the depolarization of the ventricle and the depolarization of the atrium. So that will be a long RP interval. So in those kind of patients, they are the ones that have atypical AV nodal reentrant tachycardia. So anytime you see a patient that has atypical AV nodal reentrant tachycardia, they are going to have a long RP interval, and that means they have a slow pathway. Hope this is clear. So that's why under our differentials here, you would see that long RP interval, it will be more of atypical AV nodal reentrant tachycardia. That is the slow pathway tachycardia. Is that clear?
Yes, sir.
Please, can you repeat the typical form of the AV-NRT, please?
So the typical one, as we said, using this typical one means that there's a fast pathway, there's a slow pathway. So the slow pathway receives the premature complex and it conducts slowly, right, to the ventricle and the bundle of His. As you are trying to now deploy the bundle of His, the fast pathway has taken it very fast back to the atrium. So at the time you are depolarizing the ventricle, the fast pathway has conducted back to the atrium, and it will be depolarizing the atrium at the same time you are depolarizing the ventricle. So what type of RP interval will you get?
Short RP interval.
Yeah. So anytime you see a short RP interval and it's AV nodal, it simply means the patient has a slow and a fast pathway. It simply means that the slow pathway is conducting to the ventricle, and as it's deploying the ventricle, the fast pathway have taken it back to the atrium retrogradely. Is that clear, man?
Yes, sir. Thank you very much.
Okay, so that's what I need us to understand between the two. So the moment you have got that understanding, every other thing is very, very easy. Okay. So we can, does anybody have any question? Because this is very important in diagnosing, differentiating AVRT from AVNRT and things like that. So that sometimes when you're looking at your ECG, you can actually determine the RP interval and you can state if it is AVNRT or AVRT, okay? Following the RP interval. Okay.
Hello, Prof. Hello, Prof, sir.
Yes, sir.
So just a quick one. If there is, if we could have a AVNRT that could give us long RP and the same AVNR, another AVNRT that can give us long RP, how should we be able to differentiate the two, assuming if we are giving a tracing of these two?
So you are
Thank you,
trying
sir.
to, okay, yes, sir. So you're trying to say that AVNRT differentiating if it's a slow, if it's typical or atypical on the ECG, right? As we
Very
said,
well.
typical yeah. So typical AVRT will give you a short RP interval. Atypical will give you a long RP interval. You get. So one important thing is that you would not be able to differentiate that on the ECG except during an EP study.
Oh, that's complete now. Thank you, sir.
You get what I mean? But anytime you see a short RP interval, first think of typical AVNRT. You get what I mean, sir? Anytime you see a long RP interval, think of AVRT. Okay? But what gives it out is what when you're doing the EP study.
Thank you, sir.
Okay, sir. God bless you. Okay. Yeah, so there are some time intervals we check when we do EP, but it should not be good to bore you with the time interval. But it's just important to know watch each one of them is trying to assess what's the purpose of the time interval. So anytime we say that somebody has SCL, simply means sinus cycle length, the sinus node cycle length, that means between one cycle to the next cycle. It's trying to tell you the SA node function. Okay? You expect that between one cardiac cycle to the next cardiac cycle, you want to have it within that 300 to 800 milliseconds. Sinus node recovery time. So it tells us ability of the SA node to recover from increased automaticity. So we said automaticity will be that there's another segment of the heart away from the pacemaker of the heart that is generating impulses faster than the pacemaker of the heart. It could also be inside the pacemaker of the heart, which is an extra tissue that is generating impulse faster than the pacemaker of the heart. So the question now is, which you can also stimulate yourself. Remember, I showed you all those catheters in different segments of the heart. So that catheter, you can use it to stimulate any segment of the heart that it is touching. And you stimulate it to run faster. So you pace the heart faster than the pacemaker of the heart. So the question now is, when there's an arena that is running faster than the pacemaker of the heart, and you now abort that arena, what is the time interval it takes for the SA node to recover its activity? So that will also tell us how functional the SA node is. So if it's taking longer than this specified time to recover, to take over its pacemaker role, then you can say that, oh, maybe there is a SA node dysfunction. So that's one way to diagnose abnormality of the SA node, especially in patients that have sick sinus syndrome and things like that. That's how we do it in the EP lab. So we also correct with cycle length. So this is the corrected SA node or sinus node recovery time. Now, the next is the AH. So AH simply is just trying to test the property of the AV node. So both the AH and the HV is trying to test the property of the AV node, while the SA node recovery time is trying to test the property of the SA node, if they are dysfunctional or not. So the AH also would help, as I said, will test the AV nodal property and to help us tell us if the AV node is dysfunctional, especially in patients that have complete heart block or second degree AV block. All this time interval will be long. So AH simply means the time interval, the time it takes between conduction from the atrium to the east bundle. So A for atrium, H for east. This is usually the expected time duration. You don't need to count them, usually in the cath lab. While the HV is the time interval it takes from the conduction from the east bundle to the ventricle. So for patients that have low-grade AV block, so simply means first degree AV block, working back, the AH would be longer, okay? For those that have high-grade AV block, so that means conduction from the east bundle to the ventricle is blocked. So they would have a longer HV interval, okay? So that helps you to differentiate those that are high-risk AV block and low-risk AV block. So if it is AH, you will say that it's above the east. If it's a longer HV, so you say it is infra-ischian block, okay? So the supra and the infra-ischian block, this is the time interval that separates them. So if it's longer, if AH is longer, it is at the node, but above the east. If the HV time interval is the one that is longer, you will know that it's below the node, is below the east. And anyone that has a longer HV, those are the ones that have high-grade AV block, meaning that the east bundle is not taking current easily to the ventricles. So those are the ones that will have second-degree Mobis type 2, complete heart block, and things like that. So you can see how your EP study can help you make a diagnosis of bradyarrhythmias. Okay, hope this is clear.
So I think just to repeat, please. You said a lot, so I'm a bit confused. So sorry.
Okay. So the sinus node recovery time helps us to know the functional property of the SA node. So, as I said, if there is a segment of the heart that is running faster than the SA node, that is an increased automaticity somewhere else. right? That means if it's running faster than the SA node, that means already suppressing the SA node, right? True or false?
True.
Yes. So let's say there's one focus in the atrium, left is running at 180 bits per minute. SA node is not going to run at 180 bits per minute. So it's going to suppress the SA node. Now, if we abort that focus, you want the SA node to now take over, right? The pacemaker speed of the heart. So the question is, what is the time interval it took the SA node to recover from its suppression? When that time interval is longer than this reference, that means the SA node has a problem. Do you get that?
Yes, sir. I get that.
So it
Thank
helps
you.
us to know the properties or the function of the SA node. So it's also corrected for cycle length. So that's why you have corrected SA node recovery time. Just the same way you correct for QTC. Now, the next guy is the property of the AV node. AV node would have its own properties. So one important thing we need to know is AV node dysfunction can happen within the node or below the node, that is at the east or above the east, which is at the node. Now, the question we ask ourselves is that the AV node has what we call decremental property. That means AV nodal delay. Abi? Now,
Yes, sir.
so this time interval, if you combine them together, will help us to understand why AV nodal delay should be less than 200 milliseconds, right? The PR interval. You get that?
Yes, sir.
Now, if these time intervals are longer, then that tells you that there's a problem with the AV node. Now, even though there's a problem within the AV node, the question we want to ask ourselves is that, is it above the east bundle or at the level of the east or below the east bundle? How do we separate them? What's the importance of knowing if it is at the node or at the east? This is what it means. When the patient has a first degree AV block, it means that the problem is at the AV node. It's not at the bundle of east. And it's not below the east. Okay? If a patient has a third degree AV block, the problem is beyond the AV node. Is now at the east level. Do you get that, man?
Yes, sir.
I don't know if it's my net. I don't know if my network. It appears there is a network. I don't know. Am I the only one? If
Okay,
the
sir.
network is
Yes.
If we are hearing it very well, Chief. Maybe I'm suspecting it's from the network.
maybe I'm the only one.
Professor Okopi, you never changed that network. I thought you and the governor have agreed to change your masking area.
Hello, am
Okopi. Now your
I the only one
network.
with network?
Chief Okopi, go and climb the moon.
Is there anybody there? So
I don't know how I can help Dr. Kopi. Professor Kopi, you will have to listen to the recordings. Can I go on?
go ahead, please, Prof. It's my network.
Okay, sir.
I need to climb the mango tree.
No, the moon you have to climb this time around at the moon.
Because the mango tree is not working again. Thank you, Prof.
Okay. Oh. So, I'm trying to emphasize about the features.
Okay, you just got done with third degree AV block. That when there's a third degree AV block, the problem is coming from the bundle of leads. That's where you stop.
Yes, it's usually below the AV node. Okay. So how do we know? So I just try to emphasize that a low grade, that means first degree working back, that's type 1 mobits, they are low-grade AV blocks. So that's why we don't do pacemaker for them. You get what I mean? So that means that's a problem at the, is above the east. Okay? That's at the node. Supraisian is
I don't know if I'm the only one. I'm not hearing him again.
I'm not hearing also.
No, it's very clear. You guys just applying.
It's payback time, Abby.
Yes, ma'am. Yes.
Sir, you're muted. I don't know if maybe you may be talking. You're muted, sir.
yeah. Hello? So I
Okay.
think sorry, the network. Someone called my phone. Dr. Kopi, hope you are hearing now.
Yes, sir, I'm hearing now, sir. Thank you.
Bless you, don't reach moon. Fast. Okay, so is my slide sharing?
Yes, sir, I are seeing it.
Yeah, so we're just trying to emphasize the interval we're talking about here. So AH simply tells you the time interval between the atrium and the east bundle. Okay? So that is testing the property of the AV node itself. While the time interval from conducting from the east bundle to the ventricle is the HV. Okay? So that time interval is for the infraesian, the east and the infraesial activity, while the AH is for the AV node activity. Hope I'm still audible.
Yes, sir.
Okay, so as I said, the AH will test the property of the AV node, the HV will test the property of the east bundle. Any prolonged AH interval will simply mean that patient can either have Mobitz type 1, that's working back, or first degree AV block. Any prolonged property of the HV will mean that the patient will likely have a high degree AV block, which is either Mobitz type 2, 3 to whatever is the degree or third degree AV block. So those are the patients that should get a pacemaker. Is that clear, man?
Yes, sir. Thank you, sir.
Any more question on this time interval? So then be sure it's clear. But those are just the things we check. No questions? Anything on the chat? Okay. There question? Okay. So can we move on now? Okay. So we talked, remember we said there are different catheters. So I'll go back to these catheters again in the atrium. So we can see this. Yeah, you have a question? Okay. So we can see these catheters again in the atrium. So you see the catheter in the right atrium, close to the SA node. You see a catheter in the east, touching the AV node, east catheter. So it's testing the property of the AV node. You see another catheter that can go into the coronary sinus to the left atrium, to the back of the groove between the left atrium and the left ventricle. So it's just testing the property of the left atrium. And there's another catheter we didn't show you here that will go into the right ventricle. Okay, that can get to the apex of the right ventricle. So showing us this catheter will tell us that it is monitoring activity at different segments it is touching. Okay, so I'll come to this slide. So we can see, so when we're doing EP, usually we'll have your surface ECG there. And now each of the catheters represent a segment of the heart. So remember I showed us a catheter that is in the right atrium, close to the SA node. So we usually call it on the roof of the atrium. So you call it HRA catheter, okay? So there's a catheter in the east bundle, which I showed us. There's a catheter in the coronary sinus, which I also showed us, that is monitoring the activity between the atrium, left atrium and left ventricle. And I said there's usually a catheter also in the right ventricle, right? Hope this is clear. Because everything you'll now be seeing on the tracing, this is what you'll be seeing. Is to now identify the wave pattern to make your diagnosis. Do you have any question at this stage?
No, Prof.
Okay, I just want to be sure everybody is aware so that we won't get to that wave thing and we'll be wondering, what is all this wave? Sometimes those waves can cause seizures. So, but when we understand the basics like this, I'm telling you, they're awesome. Okay.
Prof, we are following at our capacity, sir.
No worry. But I just try to break it down as much as I can. As much as I can. That's why I want to be sure you understand so that as we are moving on, it still will be clearer. You get? So if you have any questions, just ask me and okay, fine. So remember that there's always a surface ECG to help you also interpret or follow through what is happening in the catheters. Remember, we said that the coronary sinus catheter, I need to bring your attention to this. That remember, I said that it's in the coronary sinus, which is in the groove. And the coronary sinus runs in the atrioventricular groove, right? Which is behind the left atrium and left ventricle, right? And that's why when you're doing CRTD, you put the LV lead in the coronary sinus because you cannot enter into the left ventricle. So you can't puncture the left ventricle, rather you put it in the coronary sinus so that it will go to the back of the left ventricle. So what am I saying in essence? The coronary sinus does two things for you. It monitors the activity of the left atrium and the activity of the left ventricle. Do you get that?
Yes, sir.
So left atrium, how will you know? Because it's corresponding with your P wave, right? Remember the P wave, always remember your surface ECG is a summation of whatever is happening in that chamber of the heart it's representing. So P wave represents both right and left atrium, right? So if you see the P wave in the right atrium, you see the location in the HRA, the deflection, it corresponds with the P wave, Abi? If you see the P wave in the left atrium, which is represented by the coronary sinus catheter here, you can see it also corresponds with your P wave, right? So
Yes,
that
sir.
forms the right and left atrium activity for you. Remember we said there's a catheter in the right ventricle, right? and there's still a catheter in the CS, which also represents both the left atrium and left ventricle activity. So you see your QRS interval here, the QRS duration, I mean. Remember, it's a summation of both right and left ventricle, right? So you see your right ventricular activity in the early portion of the QRS. You see your left ventricular activity in the late portion of the QRS. So what are we saying in essence? That your CS catheter represents two things for you, atrial and ventricular activity for the left side. Hope you get that.
Yes, sir.
Next is the ES catheter. Remember, it's close to the touching the AV node, right? And the ES bundle. So the ES bundle, remember that we said ES bundle. So I'll show you the catheter once again so that you understand why you have these three waves. So I'll show you the catheter once again. So you see the ES catheter, It's touching the AV node. So you can see it has the property to sense activity in the atrium here. It has the ability to sense the activity going to the ventricle here, right? Because it's just touching, it's in between. Just like your CS catheter is in between left atrium and left ventricle. So also your ES catheter is in between what? Your right atrium and your right ventricle. So it will monitor activity interval from the atrium to the ES bundle, and it can also monitor activity from the ES bundle to the ventricle. So that is why you are going to have your AH activity and your HV activity. Hope that is clear.
Yes, sir.
I need to be sure others get this thing very well. Okay.
It's very clear, Prof.
Okay, great. So that is why you have on this slide now, you can see your ES bundle catheter. You will see your AH activity and your HV activity. Remember, we said that everything has a particular duration. So that means if your AH duration is prolonged, that means that you will know that it is above the node, as it's above the ES, right? So that would be like a first degree or a working back. If your HV is prolonged, that means there's a problem with conducting from the ES to the ventricle. So that means that this person would have an high-grade AV block. Oh, that is clear. So it just helps you to also make diagnosis, as we said, can make you make diagnosis of tachycardia and make you make the diagnosis of bradycardia. You will notice that the HRA catheter is only having one spike. Why? Because it's on the roof. It is on the roof. It's not getting close to the yeast, it's not getting close to the RV. It's on the roof. So it can only record only one single activity close to the SA node. Can we move on now? Hope it's clear. Hope this slide is clear. Okay, so if it's clear, we can move on to see how it's really represented on the activity. So the first thing is to know the symbols that are represented there. So you want to see your surface ECG, lead 1, AVF, V1. It's very important
Sorry,
to
Prof.
monitor your. Yeah.
Sorry, Prof. You didn't talk about the last lead, the one on the right ventricle.
The one on the right ventricle.
No.
Yeah. Yeah. So remember we said the catheter can also be in the right ventricle, right? And so you just monitor because it's close. You can see they even put it at the apex. So it can only monitor activity. It's far from the ES bundle. It is far from the atrium. So it can only record one activity. You get, unlike catheters that are in between, the ES bundle catheter is in between, the CS catheter is in between. That one can monitor activity in both chambers, upper and lower chambers. The HRA catheter is far in the eye right atrium, so it can only monitor one activity. The RV apex catheter is far into the RV apex. It can only monitor one activity. Do you now understand why some have multiple waves, why some will just have a single wave?
Yeah, Prof, we do.
Okay, fantastic. So that brings us to this. So as I said, you monitor your symbols at the corner here. So they are very easy to note. So you have the surface ECG, which is the lead 1 AVF V1. They will there's no way they will always label these catheters or electrical activity so that you know which area they are talking about. There's something I want to also bring to your attention very sharply, is that these catheters are always numbered. Some are bipolar, some are decapolar, octopolar. All they are saying is the number of electrodes on that catheter. So these catheters carry an electrode. So for the CS catheter now, it can carry up to 10 electrodes. So it will be decapolar. So all those dots you see there, you count it 1, 2, 3. It will go up to 10. Each catheter can be bipolar, tetrapolar, but most of the time bipolar. But I want to bring your attention to something. There's what is called the distal end of the catheter and the proximal end of the catheter. So either it is in the RV, it is in the RA, there's a distal end and there's a proximal end. So also this is catheter, the CS catheter, you have the distal end, the proximal end. Okay. So when you now see numbers put to that catheter, that means that they are telling you the number of poles on that catheter. If there are no numbers on it, that means they are just bipolar catheters. Okay. So if you are seeing CS1, CS2, 4, CS7, 8, 9, 10, it does tell you the number of poles on that catheter. Okay. The number of electrodes on the catheter. Okay. That can sense electrical activity. But just remember that the catheter has a distal segment, it has a proximal segment. Yeah. So why did we have to bring that up? So that when you are seeing annotations like this, you'll be able to decipher what actually they mean. Okay, so we've talked about this surface ECG. Then we also talked about when you see RV, you know you're talking about right ventricle. When you see HRV, you know it's eye right atrium. When you see the HBE, that's the East catheter. So anytime you see HBE or HIS is the East catheter. Okay, as we said, the catheter can have a proximal and a distal end. So when you see a P is proximal, the D is the distal end of the catheter. Okay. We said when you see a catheter and they label it something to 10, that means this is decapolar, number of poles on the catheter. Okay. So the numbering starts from the distal end, 1, 2 to the proximal end. I think I have a picture of something for the East catheter here that would help you. Let me stop this here. So that you can see the way they number the catheter. I want to see if, okay. So this slide will be good for us to see. So if my slide is showing, I just want to, so if this is showing, I just want to show us how they do the EP. So this is the fluoroscopy of doing the EP. So you can see the way they position the catheters, as I said. There's HRA, that's in the upper right atrium. There is the RV catheter that goes to the RV apex. Like you say, RVA now is the RV apex. There's a catheter touching the east. You get, so east catheter. or HB, there's a catheter in the CS, coronary sinus, which they've labeled for you very well, decapolar. So you can see when I said 1, 2, 3, 4, and to the end, you can see. We've already told you that there's usually a proximal end and a distal end of the catheter. So you can see the way they number the east catheter. So it simply tells you that, sir, that your 1, 2 is closer to the left atrium, while your 9, 10 is closer to the right atrium. Hope this is very clear. This is also important when you are looking at the waves. So for talking about east catheter, you can see this catheter is closer to the left, while the proximal end is closer to the right. Hope is clear. Dr. Florence,
Yes,
Dr.
Prof. It's clear. I have just a practical concern.
Yes.
Seeing these many catheters, do they have to use multiple access to get them in, or they just use one femoral access and thread all those catheters in?
Okay. I'll answer your questions. I'll answer your question. Any other question? Major question? Any other major question? Any other
Hello,
question about this catheter? Yes.
Okay, sir. Sorry, I just want to get to what you said, that 1, 2 is closer to the left atrium.
Yes. Can you see
Okay,
it?
while 9, 10, yes, it's closer to the right.
Yes. You can see it. Let's say we are looking at a chest X-ray. Which one will be the
Yes.
left side? This side, Abby? And this will be
Yes.
the right side, Abby? Yeah.
Yes. So,
Yes,
sir,
again, Prof.
the numbering, is it only for the coronary sinus catheter?
Is the one they usually will number that way.
Okay. Okay.
While
Thank you.
if they want to give you multiple for the east boundary, they will tell you proximal east and distal east.
Okay.
But sometimes, if you have number of the numbering is because of number of poles.
Yes, sir.
As you can see these poles, those dots.
Yes,
So
sir.
if I put that, if I take a catheter that has 10 poles, I should number it. Even if I throw it inside the right atrium, I should number it. For example, I can put this east catheter in the right atrium, just circle inside the right atrium. Why? There are some, a patient can have atrial flutter, right? And
Yes,
if you have
sir.
studied the wave of atrial flutter, it runs as a circuit in the atrium, right?
Yes, sir.
So I want to know where the circuit starts from and where it's ending. The only way I can know, if I put this catheter, this HRA, only here, I can't monitor what is happening here, right? Down here. I can't monitor what is happening close to the septum. Abi?
Yes, sir.
I can only monitor what is happening close to the SA node because it is just one point. Abi?
Yes, sir.
But if I put this east catheter, imagine if I put this east catheter circled inside this atrium like this. That means I can tell where it is starting from and where it is going to. Abi?
Yes, sir.
So you only use numbering when you are using the catheter that has multiple poles like this.
Okay. Thank you, Prof.
Yeah. Okay, someone wanted to ask a question again.
No, Prof, go ahead. Same question she asked.
Yeah, same.
Go ahead, it's the same question she asked.
Okay, the same question.
Yes, sir.
Okay, so has it been answered? Do you understand the answer?
Yes, it's the answer.
Okay, great. So for Dr. Conti's question, you know why I say I'll answer it later. I'll tell you why. So my first day in the EP lab when I was in India, I'll tell you my first day. We've been doing PCR and all that. Usually one puncture we take in the femoral vein. Because you have to pass everything most of the time through the femoral vein. You just take one puncture. So when I entered the EP lab that day, they asked me to take the first puncture. I took the first puncture. Now I take another puncture. I was like, what are you talking about? I just stepped behind. I don't know what this person is talking about. The doctor, the EP trainer came, took the second puncture, took the third puncture, took the fourth puncture. I was like, do you want to kill this patient? So they can take up to 4 or 5 puncture, 6 puncture in just that, because it's a vein. And it's very easy to just close the vein or close the vein back. You won't do that for an artery.
Yes, sir. Yes, sir.
So, Dr. Hope, I've been able to answer your question.
Yes, sir. Thank you, Prof.
Great. And you can use both femoral veins. Yeah. So for example, like this person now, this CS catheter, you notice is coming from top. So most likely they used either a subclavian or axillary or a jugular vein for this one.
Yeah. Yes, Prof. Yeah.
Okay. So I can slide off from this now.
Sorry, Prof. I have a question, sir.
Yes, madam.
Yes, the RAO appears similar to the LAO. Is that how it normally is? Because looking at it, the
No.
only difference is the RB apex catheter
No.
that looks somewhat different from this.
I get you. No, they are very different though.
Okay, all right.
So I'll tell you why they are different. Click one. One is that anytime we're talking about RAO, so a good RAO, a very good RAO, will shift the spine to the right side. So this is less of an RAO. So anytime we're doing procedures and you want to know if this is RAO or not, a very good RAO, you'll be seeing your spine closer to the right. A good LAO, you'll be seeing your spine closer to the left. Okay, so you can see the spine. Do you see that, man?
Yes, sir.
To the left. Number two is that for you to be sure you're in the CS, you must go LAO and your catheter or your lead, whatever you're doing in the CS, must cross the spine. So that's the importance of first LAO. The spine will be on the left, and if you are entered into the CS, especially you're doing a CRT procedure, your catheter must pass, if it's pass through the coronary sinus truly, and not the RVOT, because they are close to each other. If it has passed through the coronary sinus, the lead will cross the spine. If you are in the RVOT, the lead will not cross the spine, as you can see on this. Do you get me? So that's one way you differentiate RVOT. That's why some people do CRT and you find their wire in the RVOT. It's because they didn't do LAO. If you've done LAO, the wire, if it doesn't cross the spine, then you are not in the CS. Okay? Number three, that will make you see that this is LAO view, is that you will notice that when you're doing LAO, that means you are looking at the heart from the left side. Abi? That's the meaning of LAO. You have shifted the screen or the image, flow image to the left side. So the next thing you notice is that you see the RV apex cannot go beyond the left. This is, remember that this catheter is in the RV apex. When you see RV is in the apex, Abi, you can see the catheter is not getting close to the CS. Let me explain further what I mean. You see these two catheters on the right, on your left-hand side, the RAO catheter, Abi?
Yes, sir.
You know, it's very difficult for you to say that, am I in the RV or am I in the CS or in the LV, right? You can see they are close to each other, right?
Yes, sir.
But the moment you go LAO, you can see that the RV catheter did not cross the spine. Do you notice that?
Yeah. Yes.
So, and that's why I said, if you have entered into the RVOT, the catheter will not cross the spine. But if you are in the CS, the catheter will cross the spine. So you can see that there's a difference between RAO and LAO. You see the difference in the distance between the CS catheter and the RV catheter. Compared to when you are seeing it in RAO, you would think they are in the same distance. Can you see that?
Yes, sir.
Yeah. So that's the importance of doing an LAO and a RAO.
Thank you very much, sir.
Any more questions? Okay, so we can move on. Professor Godia, I salute you, sir. Okay, so.
Yes, Prof. Well done, sir.
I salute you. God bless you, sir.
Yes, sir. Thank you, sir.
Okay, so we can see these EP catheters now, we've identified the importance of all these catheters, right? We've seen all their locations in the heart. The HRA, the RV, the EASE catheter, the CS catheter. We all know what they are representing, right? Other important thing you should note here is that your wave you are getting should correspond at least closely to the what? Surface ECG. You get that? So for example, let's take the RV now. RV catheter. You can see it's corresponding with the QRS, right? You will see the HRA catheter is corresponding with your P wave here. Okay? You see that? Remember we said the EASE catheter is an in-between catheter between the atrium and ventricle. All right? So that means you can see some atrial activity. Label A, right? You will see your EASE spike. It's called EASE spike. H is the EASE spike, right? That means because it's touching the EASE itself. And you can see the one sensing close to the ventricle. You see the ventricular deflection wave, right? Which is also corresponding to the QRS, right? So remember when we're talking about AH, HV, you can see this is where you get that time interval. We said when the AH is prolonged, you will say that this person is above the EASE, supraEASIan, right? If the HV is prolonged, you will say that it is infraEASIan. So you can be able to tell, oh, this person has low grade or high grade AV block, right? So based on the EASE intervals, you will know who to intervene in and who not to intervene in. Okay, so as I said, the EASE signals can be distal in the catheter or proximal of the catheter. And you can close any of the channels if you don't want them. Okay. Now, CS catheter, remember they labeled it, right? From CS1 to 10. We saw how they labeled it. That means that the most distal end is the CS1 and 2, right? Which is closer to the left atrium, right? While the proximal end is closer to the right atrium. True or false?
Sure.
Yeah, great. So you can now see why your HR deflection, HRA deflection, which is high right atrium, you can see how the deflection is close to the 9 and 10 CS. Can you see that? And how it is farther away from the 1 and 2 CS. You see the distance, you see the pattern of the wave deflection. So that means you are depolarizing from the right atrium to the left atrium. You catch that? So that's a normal pattern of depolarization before you now depolarize the EASE and depolarize the ventricles. Is this clear? Remember we said the CS catheter is also in between catheter, between the left atrium and left ventricle. So you can now see the deflection of the left ventricle, right? And you can see how it corresponds to your QRS duration. So is this wave clear now?
Yes, sir.
Yes,
Because
Prof.
when you yeah, you have a question.
No, I said it's clear.
Yeah, so that anytime you are looking at an EP study, which will not be bizarre. All is just to understand the waves and you'll be able to decipher what is happening. You get? Okay. So we would now try to make some common diagnosis, okay, with our waves, okay? Now, to make it easier for us, I want to share a slide. I'm not sure is inside here. Okay. So I'm going to share this slide with us so that you see why we have to sit down to emphasize AVRT, AVNRT. Because that's the first thing you want to do when you are trying to make a diagnosis of a supraventricular tachycardia. There are other features that will help rule out others. If it's atrial flutter. If it's atrial flutter, you will see more waves in the HRA. Oh, I won't conclude everything today, but we will still look into, since you understand the basics now, we will now be, in subsequent sessions, be looking at different diagnoses and how to make that diagnosis. Hope you understand. But I just want to highlight some things. So, for example, if somebody has atrial flutter now, you would see multiple waves in the HRA even before the next cycle because it's generating flutters, right? We all know the definition of flutter. It means atrial rate is at least above 250, 250 to 300. So you'll be able to see the number of atrial waves that is happening. So you'll be able to say, oh, this is flutter. If somebody is having fibrillation, you will know that there will be irregularity in the RR interval. If somebody is having it's a complete R block now, you will note that there will be AV dissociation, meaning that between the atrium and the ventricle, there will be no coordination. You can have more P waves than the ventricular rate. We'll still look at their what do you call it? EGMs. But my purpose for tonight is actually to show you something about AVNRT and why we use the word short RP and long RP interval. Okay? So now this is very important for something. There are sometimes when the patient is unstable and is not in the arrhythmia, it might be difficult to tell what type of arrhythmia is happening. I mean, it's still in his sinus rate. So, you know, when somebody has AVNRT or AVRT, you only know when they go into the tachycardia. But if they see you regularly in their sinus state, you cannot know. Except, if the person is Wolf Parkinson White and you are seeing a delta wave, Abby, but if it's autodromic or it's AVNRT, you will not see any of those features and you will not be able to know if he's even having any arrhythmias or not. So the same thing will happen in the EP lab. If he comes into the EP lab and is in his normal sinus reading, you will not catch anything. You will just see normal waves. Abi?
Yes, sir.
However, you need to induce the arrhythmia. So anytime you are seeing arrhythmia induction, meaning that the person was in his normal sinus read, but you need to push him into the tachycardia and now see what is happening in the reading. So that's what you call induction. There are ways they do induction. They can do induction by using one of the catheters to stimulate the heart. So I forgot to inform you that when you see ABL, is ablation catheter, is the catheter you want to use to burn off the pathway. Okay? You just introduce the catheter to burn off the pathways. The ablation catheter is the one that, so ablation is like doing diathermy, as I said, generate it to burn off something. So anytime you see ABL is an ablation catheter, okay? So there's nothing odd about it. It has a distal end and a proximal end. Now, you can use any of these catheters to stimulate. Either is the HRF catheter, the EASE catheter, the CS catheter, any of these catheter, RV catheter, can use it to stimulate, like you are pacing, so that the patient will go into the tachycardia. Do you get it?
Yes, sir.
Now, so in this patient, I will show you where they started inducing. But I want to explain one feature again to take us back to the short RP interval, a typical AVNRT. Remember, we said the typical AVNRT will have a short RP interval, right?
Yes, sir.
Typical one. And we explained the reason that this patient will have a fast, slow pathway, right? It simply means that when you are depolarizing the ventricle through the slow pathway, the fast pathway has taken the current up to quickly depolarize the atrium. So the time you are depolarizing the ventricle, the fast pathway has also gotten to the atrium to depolarize the atrium. Abi? So that means you are depolarizing the atrium and the ventricle at the same time.
So,
Do you get that? I need to be
yes,
sure
sir.
everybody gets this short RP interval because it's the sweetest part of EP. Is there any question on this slow and fast pathway? Slow pathway is carrying the conduction down to the ventricle, and as it's using the East bundle and others to depolarize the ventricle, the fast pathway has taken the conduction back up very fast to go and depolarize the atrium. So at that time, atrium and ventricle would collide in depolarization.
Yes,
Is
sir.
that clear? And we've
Yes, sir.
said that that's usually started by a pre-excitation or a pre-ectopic, I mean. An ectopic is what starts it. That's what I'm trying to emphasize. Okay? So what if we induce the ectopic ourselves? We pay space, and we just induce one ectopic, and if you just enter into the circuit, and the slow pathway will just fall for it and carry it down, and the fast pathway will just quickly pick it up and send it to the atrium. And as the slow pathway is depolarizing the ventricle, the fast pathway has quickly gone up to depolarize the atrium. Wow! And you just have a concurrent depolarization of the atrium and ventricle at the same time. So that would be a short therapy interval. Yes, true or false?
True.
Yeah. So if you got that, then that comes to this. So do you see this now? So look at this very well. You see the patient is in the sinus rhythm, right? HRA, you can see HRA catheter, right? You can see
Yes,
the east catheter. You can have proximal east, mid east, distal east. You can have proximal CS and CS1 to whatever. And remember, we said distal CS is closer to the left atrium, right? Proximal CS is closer to the what? Right atrium, right? Then you can now see your RV apex, RVA proximal apex, RV, which coincides with your QRS, right? So
yes,
this
sir.
is normal sinus rhythm, right? So P wave came far before the V wave, right?
Yes, sir.
So the next thing happened. So we want to now push this patient into a premature. So this first cycle, you see, it follows the normal pattern, right?
Yes, sir.
The second cycle also followed. P wave came, East catheter, CS, and you have the RV apex, right? Fell into the normal cycle. Abi?
Yes, sir.
Okay, good. Do you now see what happened around there? So this one too, you will notice this is the third cycle is also happening, Abi, following into his what?
Yeah.
Okay. Now, I'll now show you something. Look at the time interval between this first cycle and the second cycle. Abi, it's long now.
Yeah.
Let's say whatever, 600 milliseconds. They've been giving us the time interval, 600. Look at the second time interval. It looks regular now, Abi. Between here and here, it also looks like 600, Abi.
Yes.
But the next question you ask yourself is that, is it the same interval between this and this? Between the third and the fourth cycle?
I think it was a premature.
Exactly, there was a premature complex. Abi?
Yes, sir.
That happened here. So the question you now ask yourself that after the premature, the onset of fast now happened. Abi? You can see the interval is now shorter, Abi, compared to where we started from. So that's what they call you the S2 when the premature complex happened, 340. It's shortened. You can see it's almost like half of the where we started from, right? Now, the question you now ask yourself is that what happened next? Look at where the P wave is. Look at where the QRS is. I mean, the R wave is. Can't you see that P wave, that's HRA, is CS, RV are happening at the same time. Do you notice that? They are all
Yeah.
happening at the same time. Look at this cycle also. Remember we said the slow pathway that started this problem will go and depolize the ventricle, while the fast pathway has quickly carried it up to go and depolize the atrium. Do you see that everything almost happening at the same time? Look at this again. Everything almost happening at the same, right?
Yeah.
Time. So that is the diagnosis of what? AV, typical AVNRT. Do you get that?
Yes, sir.
Do you now understand why I have to sit down to explain the entrant tachycardia? Because I'm sure everybody wondering, is it I want to do, I want to do EP. When you understand the mechanism, it will be very easy when you are looking at the graph. So do you have any question on this? That's why I need to be sure everybody
Thank you, sir.
understood.
Thank you, sir, for the teaching, sir. I just want to ask you a question, sir. I once read that the RP you talked about, using the surface ECG, you could find a retrograde P wave just after the QRS. I think V1, maybe V2, I'm not sure of the second lead. Just to guide us during EP, I don't know if using the surface ECG, if we have V1, can it show something that can look like a retrograde P wave that could serve as a guide? Because what you showed us now when it was fast looks like if we have a surface ECG that could show that retrograde P wave, it could actually fall in line with this rapid one you showed us now. I don't know if my question makes a little sense.
Yeah, I get your question.
Okay, sir. Thank you, sir.
So
my question is that if it's part of the surface ECG, if V1 is there, can he show that retrograde P wave? It might be easy to just use to pick this rapid phase, which will likely coincide with that retrograde P wave, sir.
Yes, thank you.
Yes, sir.
Sorry. So I'll answer your question. Okay, so you can see the surface ECG, right? Lead 1, lead 2, and V1, right? Remember we said you use your surface ECG to also time whatever activity is happening in the chambers of the heart, right? So if you are seeing an HRA, right? So that means it's corresponding with around the P wave, right? Okay. If you are seeing your V waves, that means corresponding close. Might not apparently fall at the same time, but it's going to correspond to the timing, okay, of the QRS, right? You get that? So your P, your QRS. Your P, right? Your QRS, right?
Yes, sir.
Your P, your QRS. So when the premature,
yes, sir.
So you can now see your P just immediately after your
QRS.
You get what I mean? So that's your, you get what I mean? Just immediately after the QRS. Before it is far away before the QRS, right? You get what I mean?
Yes, sir. Exactly there.
But now, it's now just close to the QRS, which will now use the word RP interval. So if you measure the interval here, it should be less than 70 milliseconds, okay? So that's what, so it's part of the things you make as a diagnosis on your EP when the tachycardia starts to tell you that it's a short RP what? Interval. You get that, sir?
Yes, sir. Thank you, sir. Very clear, sir. Thank you, sir.
Okay. Any more questions?
And sorry, so I want to ask a question. Maybe after the premature ventricular complex or contraction, can the P wave sometimes be buried in the QRS complex?
Yes, no, it's possible. No? So what you just help you track it, trace it, and just look at it. That's why there's a catheter in HRA that helps you mark your P waves. Huh?
Okay.
So even if it's buried, at least your HRA is telling you that
yes,
this
okay,
is
that's
the,
true. Okay.
you get what I mean?
Yes,
This
I do.
guide helping you to track out where the location of your P wave should be.
Okay. Okay.
You get it?
Okay, because
So looking
that
at
only
the
shows
surface
us.
image, it might be difficult sometimes to see. Hello?
Okay.
So using that is
Okay,
looking
sir.
at the surface image might be difficult sometimes to see, but that's why you have a marker in the chambers
Okay.
to help you from the beginning, to help you know that this
Okay.
is going to be the location of where
Okay.
this will be.
Okay.
You get
Okay,
what I
sir.
mean?
Okay, sir. Okay, so in such instance, the HRA is best to locate the P wave, because if we look at the his, we may not so identify,
that's the
because the
finder.
his actually carries both the atrial and the ventricular conduction pattern. So, but when we look at the RA will actually help us to locate where the P wave actually was conducted, right, sir?
Yes.
Okay.
Yes. So as I said, it's the purpose of is the duty of the HRA to help you find where your P wave is. It is the duty of your RV catheter to help you find where your QRS is.
Okay.
Those are the importance of those.
Thank you, sir.
Excuse me, sir. The HRA in this instance, when it became abnormal, seems shorter compared to what we had initially.
And I'll
which
ask you
was
why.
long.
Why?
The premature is the premature, the AP, like an APC or something, sir.
No, that's
premature,
that's not
okay,
the
or a retrograde
exactly.
P wave. Retrograde P wave.
Remember when it was in sinus reading, it is coming from the SA node, Abi?
Yes, sir.
And I showed you the HRA catheter close to the SA node, Abi?
Yes.
And that's
yes,
where it's generating the activity from. That's why the amplitude is high. Right?
Okay.
But now, this is AVNRT. That means whatever is depolarizing the atrium is coming from where? AV node.
Yes, sir.
Do you get that, sir?
Yes, sir. Clear.
So it is just receiving signal from far. The signal is actually coming from the AV node now, not from the SA node. So you
Very
cannot
clear,
get
sir.
high amplitude. Okay. Great.
Very clear, sir. Thank you, sir.
Okay. Okay, so I guess our time is fast spent. I will leave the slides. I'll send the slides to the group. So be able to now study AVRT, orthodromic, antidromic, and the others. So any question on this we've done so far? You know, those days, so Dr. Kopi will say that when we are already going beyond 10, that this EP can blow the head. Chief Okopi, are you still here?
Yeah, so I was about typing exactly what you are saying on the chat box. This EP study is better.
Sometimes you can cause seizures.
Yeah, it can cause of delta waves on the brain. So I think it would be nice that we take it in aliquot.
Yeah, sure. So at least we've understood this. I'll just drop the slide on the platform. I think I've actually sent it before. There was a time I tried.
Yes, sir.
Pacemaker.
But
we can also always be sent.
All right, sir. Thank
Okay,
you, sir.
so we'll take it from here. So the next one to be discussed will be the AVRTs, and we'll now go into atrial tachycardic, atrial flutter, atrial this and all that. Okay.
Okay, sir. Thank you, sir.
Thank you so much.
Thank you, everyone.
Thank you so much.
Thank you. Thank you so much, sir. I really appreciate it. Thank you. Okay. Okay.